what's clinical, it's different.
Okay, good afternoon, everybody. I'm Michel Comorbidities from Paris, France, and I'm delighted to co-chair this session on implementation of guidelines together with Professor Ponikowski from Wrocław, Poland. We have outstanding speakers today, Professor Rosano, the President-elect of HFA, Professor Mullens from Ghent, and we have two outstanding discussants, Professor Thomas Lutscher from London or Zurich, or London and Zurich, and Professor Weidinger, our President-elect of the ESC from Vienna. So without further ado, I would like to invite Professor Rosano to deliver his lecture on how to implement the new guidelines in clinical practice. Giuseppe, please.
Thank you very much. And this is my declaration of interest for this talk. Now, with the guidelines have evolved over time from a stepwise approach that was started in 2012 and then reiterated in 2016, where we were suggesting the use of the different drugs in a stepwise fashion. So starting with those drugs that were discovered or that have demonstrated first efficacy in the treatment of heart failure, and then suggesting all the other drugs in the order where they've been discovered. Now, the new guidelines, the 2021 ESC guidelines, have been a sort of Copernican revolution in terms of how to implement medical therapies in patients with heart failure, as we kept we have a class 1A recommendation for the ACE inhibitors, beta blockers, MRAs, and dapagliflozin and empagliflozin only for the treatment, for the reduction of mortality and hospitalizations in patients with heart failure. But what is important is that we've suggested to use not longer the stepwise approach, but to use all the drugs together and start them whenever possible in patients with heart failure. Then, once you've implemented the 4 foundation therapies and diuretics according to congestion, then according to whether the patient is still symptomatic, then you can consider the class 2 recommendations, and according to the left ventricular function, for instance, sinus rhythm, the width of QRS, then the indication for ICD, CRT, or combination. With the guidelines, there was a first attempt to phenotype patients with heart failure in order to give suggestion on how to use class 1 and class 2 drugs or interventions in patients with different phenotypes. For example, for patients with atrial fibrillation, there's an indication for if you opt for a rate control to use digoxin, if you want to attempt, and if there's an indication to attempt the restoration of sinus rhythm, the pulmonary vein ablation. For patients with coronary artery disease and symptomatic angina, the coronary artery bypass, and eventually intervention. For those patients with iron deficiency, ferric carboxymaltose, and so on and so forth. So that was the first attempt to identify the different subgroups where different interventions can have a better efficacy. But what is important is that what we have learned in the past few years is that comprehensive therapy is more effective than conventional therapies or the stepwise up-titration of conventional therapy in improving survival, event-free survival that includes hospitalizations. And you can see here in these first few months and how important is the efficacy on hospitalization, especially in younger patients. The problem is how we do implement medical therapies in our patients, and we have to face two different type of patients. There are patients who are already on 2 or more agents, so patients who have already been diagnosed with heart failure, where we need to implement medical therapies. Maybe they're not been started on an MRA, or they've not been started on an SGLT2 inhibitor, or those patients who are naive or are taking one agent. I have to say that this group of patients is very rare. At least it's very rare in the secondary and tertiary centers, where we tend to see more patients that come already with, at least with a beta blocker, an ACE inhibitor, or an ACE inhibitor, an MRA, because of other reasons, because of underlying ischemic heart disease, because of the left ventricular dysfunction, post-MI, or because of hypertension and other risk factors. So the true naive patients are difficult to find in clinical practice. Of course, they are more numerous in primary care, and they are less frequent in tertiary centers. So we have the patients we see are often those with 2 or more agents. So for those who are naive, we always face the issue, how can we start? Because if we start according to the stepwise approach, then we start with this inhibitor, we escalate the dose, then we start with the beta blocker, we escalate the dose. That can take from 6 to 12 months to get a full implementation, and we'll miss what is the critical phase of the vulnerable period. Now we know from CBS3 that we can start an ACE inhibitor and a beta blocker together. What is important is that you always need to start the ACE inhibitors together with the beta blocker, and not start the beta blocker before the ACE inhibitor, because in CBS3, patients who have started on a beta blocker before starting an ACE inhibitor had an increased risk of hospitalization. So you can start the two together, but never start a beta blocker before of an ACE inhibitor. Of course, you can start the SGLT2 inhibitors whenever you wish, because they have a neutral effect on blood pressure and heart rate, and therefore from an hemodynamic point of view is easier, whilst you may wish to have a stepwise approach for the MRAs, and eventually, if there's an indication, to switch the ACE inhibitor to an ARNI in the due course. But when we look at the clinical practice, and we see patients that we face every day, we look at their reality. Their reality is not the reality of the clinical trials, where patients are super-selected. And this is a very good example. This is the CB-CELT. That is a trial where there was a forced-up titration of bisoprolol and carvedilol in patients with heart failure. And as you can see, only 25% of patients managed to get more than 50% of the target dose of the beta blocker. The main reason were because of heart rate, because of AV blocks, or worsening of heart failure. So that is the reality, and we also know from all sorts of trials, going by either beta blocker trials, beta blockers plus ivabradine trials, that if you opt for a guideline recommended, what it was then guideline recommended, so an escalation of beta blocker dose according and try to reach the maximum dose, or you choose to have a target of heart rate, you have the same effect on survival. So it doesn't matter whether you achieve less than 60 beats per minute in patients in sinus rhythm, for example, with a full dose of beta blocker, or you achieve that in combination with other agents. And indeed, we have evidence from smaller clinical trials that if you're using a combination therapy of ivabradine and beta blockers, then you have a significant better control of heart rate, and at the end, after 3 months, you get higher dose of beta blockers compared to those patients who have started only a beta blocker. And I have to say, and Professor Komajda can confirm, because he was one of the drivers behind the studies, the SHIFT study actually was not a study comparing ivabradine with placebo, but was a study that was comparing two different strategies. It was either beta blockers or beta blockers plus ivabradine, and basically showed that that was a successful intervention. Also, we've often limited in the possibility of implementing our medical therapies because of side effects and comorbidities. And we know that the effect of some of the drugs, like, for example, RASI and the ARNI on angioedema, or on the effect on cough, we know the effect on hypotension and bradycardia. I've mentioned the beta blockers, but also we know well that the ACE inhibitors and the MRAs are also very important. I come from a generation where when we used to start the beta blockers, the ACE inhibitors, we used to keep patients in the waiting room for 2 hours before sending them home because of the fear of hypotension. Now, then we can have also poor patient tolerance because of fatigue, and that is important, but also the possibility of hyperkalemia. And there are different reasons for the underuse of the comprehensive medical therapy in patients with heart failure. Some is for sure due to therapeutic inertia. Some is the safety and tolerability, the presence of side effects. The fact that patients have been included in clinical trials actually do not represent patients we have in front of us in clinic. And we can have ways of improving the adherence to guideline-directed medical therapy, like, for example, the starting medications in hospital before discharge, the multidisciplinary management, and it is very important, the collaboration with nurses and with pharmacists and with healthcare professionals in order to have a better adherence and better up-titration of medical therapy. But what is also emerging, and is very important, is the use of comprehensive care that includes also digital health in favoring in helping in the up-titration of medical therapy. Of course, we have to face issues with medications. Hyperkalemia is one of the complications that we often see. We can see that 15% of patients that use RASI tend to have more than one episode of moderate to severe hyperkalemia per year during treatment. And we know that if we reduce RASI therapy following an episode of hyperkalemia, we see that, and we reduce to suboptimal dose or we discontinue the treatment, that leads to an increase in the future risk of hospitalization. So what happens is that if you get an episode of hyperkalemia and you reduce the dose and then you don't re-challenge the patient in order to try to at least reinstate RASI, then that patient is at increased risk of future event and hospitalizations. And several years ago, a few years ago, actually, it was 4 years ago, we published with the Working Group of Pharmacology of the European Society of Cardiology a consensus document on how to approach hyperkalemia, how to use the new drugs that are on the horizon, that were at the horizon at that time, and they're now a reality, so the potassium binder. And you can go and see, and you can find that patients with recurrent hyperkalemia on RASI, there's a clear indication for the use of potassium binders. Those patients who have had an episode of hyperkalemia that has been resolved and they are not on optimal RASI therapy, there is a suggestion of up-titrate RASI therapy again and use the potassium binder binders if needed. In those patients that have a potassium level between 5 and 6.5, then do not discontinue RASI, but use from the beginning a potassium binder, because we know that in these patients a potassium binder can reduce significantly and very rapidly potassium levels within a few hours. So we know that also we have the newer drug that favor the reduction of hyperkalemia and reduce the occurrence of hyperkalemia in patients with heart failure taking RASI therapy. And this is the pooled analysis of the incidence of hyperkalemia in patients who are receiving dapagliflozin. And as you can see, regardless of ACE inhibitors used, regarding the presence of MRAs, ACE inhibitors, or GFR, there is a consistent reduction of the occurrence of hyperkalemia with the use of dapagliflozin. Similar data, albeit less strong, have been reported with empagliflozin. Similar data we have also with vericiguat. So vericiguat in patients with a different threshold, with different range of EGFR, or reduce the occurrence of hyperkalemia compared to placebo. So basically the message here is we have the new medications, first of all the SGLT2 inhibitors, in those patients with worsening heart failure, vericiguat, they should be implemented in clinical practice. They may favor the further implementation of ACE inhibitors and MRAs because they reduce the possibility of hyperkalemia. The other problem is the change in blood pressure. And we know that ACE inhibitors and beta blockers do reduce blood pressure, but we also know that when we switch to sacubitril valsartan, we have a significant reduction in blood pressure. And these are data of comparing sacubitril valsartan with valsartan, basically showing that there's a further additive effect on blood pressure. And in the previous guideline, actually, we had suggested that you may use different strategies in order to offset that small reduction in blood pressure. That is basically reducing the beta blocker and use it in combination with ivabradine. In that case, you give a little bit of that spending function and giving room for the your implementation of sacubitril valsartan. We have less of an effect, or we have no effect on blood pressure with SGLT2 inhibitors. These are data from DAPA-HF, and you can see that in those patients, the patients that are more difficult, those patients with a blood pressure around 110 beats per minute, there was virtually no change in blood pressure with dapagliflozin. So basically that tells you that you can just give the drug and forget in terms of blood pressure, because it's not going to induce any hypotension. And this is why I was suggesting earlier that when you can start an ACE inhibitor, beta blocker, and an SGLT2 together in naive patients, because that is not going to affect blood pressure. What is important is that the effect is preserved of the drug is preserved all across the board of blood pressure values. Similar data we have with vericiguat, and you can see that regardless of age, regardless of the starting blood pressure values, more than 110, or even actually patients with less than 110 millimeters of mercury, you see that with vericiguat you don't see any significant reduction in blood pressure. More recently, and this is data that we've analyzed together with Gianluigi Savarese from the Swedish HF registry, we have demonstrated that there's actually on mortality, and these are the data that were missing, because whenever we were suggesting that you can use lower dose of all the medications together, there was always a missed link. That was the absence of real-world data. Basically, we've demonstrated that if you use all the different drugs in combination at different doses, you have a similar, if not better, efficacy of using one or more classes at full dose. So basically, it is important to understand that it's better to have all the drugs on board rather than waiting and trying to up-titrate to maximum tolerated dose, one drug after the other. Now, probably you have seen this slide presented many times during the meeting, and this was the attempt that we, with the HFA, have tried to simplify the approach for the treatment of heart failure and the implementation of medical therapy. Basically, we realized that there are some spending functions. So you can spend so much on blood pressure, you can spend so much on heart rate, you can spend so much on renal function with the use of the different drugs. And therefore, you have different phenotypes according to heart rate, according to blood pressure, a presence or not of CKD, or atrial fibrillation. And then you can have patients with low heart rate, high heart rate, low blood pressure, high blood pressure, different renal function. And you can see that with all these variables, you can build up to 58 different phenotypes. And these phenotypes are important because they will guide you on how to implement the different medical therapies. Yes. It gave me 2 more minutes here. Okay. So basically, you can take patients with different type of medications, and if, for example, for those with low blood pressure and low heart rate, you can see that you should implement less your some of the medications. So the main message is that the guidelines suggest a simultaneous implementation of the 4 foundation therapies. The hierarchical up titration may take up several months, missing the vulnerable phase. Therefore, what is warranted is the simultaneous initiation of the class 1 medications at any encounter, not at discharge, not in the hospital, but whenever you see a patient, any encounter, you have to start all the class 1A recommendation and implement that according to the phenotypes rather than directed by the target dose that are never achieved or very seldomly achieved in clinical practice. Thank you very much for it.
Thank you. Giuseppe, thank you very much for this excellent overview. For the sake of time, I would kindly ask you to keep all your questions for all the speakers at the end, so there will be time at the end of the session to raise ask all the questions. So it's now my great pleasure to invite Professor Moulens from Belgium to give us a lecture on how to implement the whole device story into the current clinical practice and how to optimize the device treatment, obviously using the existing guidelines. Wilfried.
Thank you, Piotr, for the introduction. So how to combine CRT, ICD with medical therapy, what to use at what moment in time. These are my disclosures. I'll try to explain why and how. I believe we should improve device care, and drugs and devices are never mutually exclusive. They should be used in combination to have a synergistic effect. So if you ask me what is the right timing, it depends on what you want. What do you mean with timing? Is it timing in relation to the disease diagnosis? Is it timing in relation to medication? Assuming it's always first drugs and then a device. Is that correct? Or is it timing in relation to hospitalization? Do I do the implantation during the hospitalization of acute heart failure, or do I wait? And that's the difficult answer we have to tackle here. I think good timing means that you don't hesitate to use it when the time is right, but don't rush in unless the conditions demand for it. It's difficult. It's not easy, but it's probably doable. So let us go first at the ICD. Who needs the ICD? Well, this is not what you want. We thought he was doing okay, and then he was gone. And this patient will never come back. They will not come back to you to complain that they're dead, because they're dead. So they cannot complain. So every time, really every time I see a heart failure patient, I look at this risk ratio. What is the risk for this patient to die sudden, divided by the risk that he would die non-sudden? And that is not so difficult. In primary prevention, we say it's 3 to 5% per year. In secondary prevention, it's 10 to 20% per year. And you have to do the match. Where is my patient? Is it primary or is it secondary? And that is the goal for every encounter that you have. The guidelines will guide you through this. Secondary prevention is really clear. It's class 1A indication. Therefore, we don't wait. That's as soon as possible. Secondary prevention without any reversible cause, of course, that's ICD during the hospitalization, or even giving them a VAST before I send them home. No discussion. I'm not going to wait for medical therapy to kick in. Primary prevention, the guidelines that ERA and HFA that we wrote together stated 3 months of optical medical therapy. Now, I must say that the ICD trials never specified timing implantation in relation to this disease severity, medication use, or heart failure hospitalization. Yes, it's in there, medical therapy, but it's never really specified that they needed to be on so many months of medical therapy. So should we delay ICD implantation for medication to kick in? That's the real question for the ICD first. I think the answer is yes, because medical therapy will improve ejection fraction, and therefore the ICD indication is gone. We like simple approaches, simple messages. It's probably not as simple as I'm telling you, but anyway, let's look at the change in ejection fraction in response to medical therapy. These trials have been done consecutively. So the beta blockers show an impressive improvement in ejection fraction of about 7%. Then it was ACE inhibition was like 3%, MRAs is also 3%, so you already have an ejection fraction improvement of about 10% in the average patient that you diagnose with heart failure if you put them on these 3 drugs. Now bear in mind that we have this not really novel drug, it's ARNI. And ARNI also shown that if you are an ACE progressor, so you turned out to still have a poor ejection fraction under ACE, and you switch that person, that you improve ejection fraction even further. So we have 4 drugs, including SGLT2, that might lead to a positive reverse remodeling. So the answer is yes, it's a correct approach, but I need 3 conditions to be fulfilled. First of all, you have to re-evaluate the ejection fraction after 3 months of medical therapy. You're not going to say, come back in a year. That's not what we want. 3 months, maximum. Secondly, I'm a physician. I have to look at my patient. I have to individualize that decision. If the baseline risk is higher than 3 to 5%, because this person has a lot of scar, he has a genetic mutation favoring a lot of sudden cardiac death, I'm not going to wait. And if my ejection fraction is persistently low, I should go for the ICD. Now the third rule is really important because we're not doing that. We're not doing that. If you look at emperor reduced, implantations rates of ICD were 30%, ejection fraction 24%. So even in the best randomized controlled trial settings, 70% of the patients who should have gotten an ICD did not get the ICD. Also bear in mind that you're not cured if you give these drugs. The event rates are still 20% at 2 years. 20% still event rates. A lot of this event rate is heart failure hospitalization and all-cause mortality, but it's also sudden cardiac death. And we all use this slide to show that medical therapy is extremely beneficial to reduce sudden cardiac death. And that's absolutely true. But if you take away these control groups that did not get a beta blocker, did not get an MRA, did not get an ARNI or a RAS inhibition, and you compare, for example, the sudden cardiac death rates of SCUT-HEFT, which was a primary prevention ICD trial, non-ischemics and ischemics, with Paradigm, it's exactly the same. It's 3% per year. So if your patient is on ARNI, on a beta blocker, on an MRA, and on an SGLT2, and his ejection fraction is still poor, he has a chance of at least 3% to die sudden. That's not always VT or VF, can also be a bradycardia indication, but they still will die sudden. So it doesn't take away the indication to go for the ICD. And I know ERA downgraded for non-ischemics ICD indication from a class 1 to a 2A indication. I was part of that guideline. I was not in favor of that. I think we should have taken this approach, like HFA took, that you have to individualize again. If the likelihood is high that you're going to die from a non-sudden cardiac death, it's okay to wait a little bit longer with the ICD or not implant the ICD. But otherwise, I think there's still room for ICDs in non-ischemics. And I think the lack of implantation is not related to a gap in the guidelines, but it's related more to a gap in our healthcare organizations. But we are physicians. We have to prove that we can do better than what we have been doing so far. What about CRT? CRT medical therapy, there is no timing. It's despite optical medical therapy. There's nothing in there which says you have to wait for 3 months. So let us look at 3 options for timing of CRT. First option is drugs, then CRT. That's what most of you are doing. Second option is CRT and then drugs. Almost nobody is doing that unless you have, for example, a patient with a total AV nodal block, poor ejection fraction, then you just go for the CRT and then you give the drugs. I'm more in favor of this, to be very honest. It's CRT and already, or it's drugs and already thinking of the CRT, and this might be the option that you should also consider a little bit more. And I'm going to give you several reasons for that. The first thing is, should we delay the implantation because ejection fraction is going to improve? Yes, that's what all of us think, because these drugs work extremely well. However, looking back at the trials, none of the trials in medical therapy included QRS duration as an inclusion criteria. Most of the patients in the medical therapy arms have a narrow QRS, not a wide QRS. So what is the effect of drugs on a patient with a left bundle branch block? Is it similarly effective? And it's probably not. So let us look, for example, at a lot of data. First of all, only the minority of patients who are sent for CRT are on the maximum recommended amount of dosages. It's 20% for ACE, 30% for ACE, 20% for beta blocker. It might be physician inertia, but a lot of that has to do with low blood pressure in an LBB patient or hypotension or bradycardia, making it impossible to actually up-titrate the beta blocker. Even more important, two different trials, or two different observations, not trials, where they looked at the changes in ejection fraction over time with medical therapy in a narrow versus a wide QRS population. In the narrow, it's 8%, a little bit what I was alluding to before. In the right, it's only 2%. This means that you almost do not get an improvement in ejection fraction if you have a wide QRS. Bear in mind that the patients with a wide QRS, their natural prognosis is a lot worse than if you would have a narrow QRS. So if you wait longer, there's more to lose, maybe less to gain with delaying your decision to implant. And that turns out to be true with ejection fraction improvement as well. This is an observational study done where they waited more than 9 months for the CRT implant versus an earlier implant, and you could see that ejection fraction improvement was significantly higher if they did an earlier implant. Waiting a longer time, we showed that already almost a decade ago, also leads to more heart failure hospitalizations afterwards because you let that heart struggle with the disease longer. And that's probably not a wise idea. Similar data coming from the States, where they looked at patients who came in with a wide QRS and had an indication for CRT. And they said, if we do it now, or we wait a little bit more. If they did it during that hospitalization, they saw a spectacular improvement in outcome versus delaying that decision for more than 3 months. So I think the efficacy of medical treatment on remodeling and hard endpoint is limited in patients with an LBB. So this suggests to consider CRT a little bit sooner. Now, this is part of a lot of problems related to device therapy. And the biggest problem, really the biggest problem for the non-responders is the no implant problem. These are the numbers of CRT implantations in Europe as assessed by 1 million inhabitants yearly. And it's about 150 implants per year per million inhabitants. We should be implanting, according to the ERA White Book, 400 per year. That means that 1 out of 3 patients with a wide QRS and a low ejection fraction actually gets a CRT device. And 2 out of 3 do not get the device, while they have a class 1A or 2A indication. So should CRT be considered as a pivotal therapy for these type of patients? My answer is absolutely yes. Because they feel better, they're hospitalized less, they live longer, they deteriorate less rapidly. It's not a too difficult technique and an acceptable risk and an affordable price. So why don't we do it? Why every time, in every meeting, we talk about the bad things of a device? And we say, we look at CRT with an unprecedented scrutiny, despite its firmly established benefits on mortality and morbidity and quality of life in several trials. That is why HFA, ERA, EACVI, and ESC took up the daunting task to try to improve not only the implementation rate, but also the optimization of the patient who gets a device. That has been really documented in this, I think it's a really nice document, and there are 4 pillars in this document. Overcome the underutilization of devices. I'm not advocating going to the narrow QRS, I'm just saying do it in a class 1 patient, please. Why don't you do it? Secondly, deal with the non-response issue, educate your patients and your physicians on pre-implant characteristics, and offer a structured guide for a better follow-up. CRT, ladies and gentlemen, it will not cure your heart failure. It is a treatment to ameliorate the contribution of the synchrony to the heart failure syndrome, which will ultimately reduce heart failure-related morbidity and mortality. It's not a yes or no phenomenon. It doesn't happen like that in real life. So I hate the word responders to a therapy, especially to CRT. It killed the field. Talking about he's a responder, he's not a non-responder, it's completely foolish. We should talk about disease modification. I don't know of any patient with a wide QRS, a low ejection fraction that got a CRT that went worse. They all get better. They all get better. But there are different ranges of disease modification, of course, but every one of them is getting better or disease deterioration goes less rapidly. This red line beneath there, that's in the narrow QRS. We don't go in the narrow QRS. And if we were oncologists, we would be really happy because all of our patients have at least a partial remission of their disease. So it's a spectacular therapy, but it's not drugs, device, wait. No, it's drugs, device, drugs again. You can improve the optimization of medical therapy after you've done the implantation because there's more blood pressure, 10%. There is not a problem anymore with bradycardia. So if you up-titrate ACE, RAS, beta blockers post the implantation, you'll have even a better outcome. It's not only drugs. There are a lot of things that you can optimize because this is a heart failure patient. It's a chronic disease which will never be cured. So I can optimize the device settings. I can optimize arrhythmia care. I can optimize the lead position if it was placed in a wrong position. I can do so many things. And I need to collaborate with other physicians, with primary care, with heart failure nurses, with EP nurses. I need to do telemonitoring. And if I do all of that, shown in a very nice trial in the US, you have a better outcome. You can really make the difference. So does it exist, complete heart failure reversal after CRT? Yes, it exists. And this is what we call the super responder. I don't want to talk about responder anymore, but sometimes I see this. So sometimes electrical dyssynchrony is the cause of the problem. And in those patients, of course you ask yourself, can I take away the drug? Can I stop the medication? We've done that in a small trial and we stopped the drugs in such a patient and it turns out to be safe if you pay close attention in a primary prevention, no scar, no VTs. This is not a TRET-HF patient with a non-ischemic cardiomyopathy in a narrow QRS where you stop the drugs after reverse remodeling. This is a patient, 5% of your patients after CRT, not more, that you probably can do this. So these are my conclusions. Primary prevention ICD, it's feasible to wait for 3 months, probably, but an LBB is a significant predictor of decreased rates of LV functional recovery and it has an important higher risk. Many patients, if not all, will not improve above 35% if they have a left bundle bench block, and the delaying of the CRT might lead to less LV recovery and more adverse events. The position statement endorsed by all the associations encourage you to think at least to do it a little bit sooner in the wide QRSs. Heart failure is never cured with a device, so continue to optimize your treatment, but the number one reason for a no response is a no implant. Thank you.
Thank you very much, Dr. Mullens, for a very nice and very clear lecture. So, in order to structure the discussion, I would like to invite Professor Weidinger to comment on Giuseppe Rosano's lecture, and maybe Tom will focus on Dr. Mullens. But anyway, we can interject, and if there are questions, please feel free to go to the microphones. So, Franz.
Yeah, well, I think Giuseppe raised very important points about the availability of 4 drugs that all have been proven to reduce mortality and improve the outcome of patients with hard clinical endpoints. And of course, we, after releasing guidelines, have to take care how to implement them and how many patients can really benefit from these guidelines in clinical practice and in reality. So I think it's the role of HFA, but also ESC, to really look for reasons why do not all patients, not adequate numbers of patients benefit from all the potential benefit from these therapies. I think you made this very good point. And when I look at your timeline that it takes maybe 56 weeks to establish all available drugs in a given patient. This also raises the issue of different healthcare settings that it may require, in hospital, out of hospital, different healthcare settings which make it more difficult to really ascertain the adequate follow-up of patients, and really challenging to not lose the patient, to not miss the right moment to add another drug or to increase the dose of a given combination therapy. So I think it's much about organizational issues as well, as you raised. So I think that's an important point to consider for every one of us who deals with patients.
Thank you, Franz. Giuseppe, there are 2 points which were not discussed, and if you could kindly comment. One is the cost of medications, which may be an issue in some countries. And secondly, do you believe that polypharmacy may also influence adherence to guideline-recommended therapies?
Sure.
And if you were to advise a company to discuss a combination pill, which one would be your preferred one?
So regarding costs, I think that
important issue.
I think cost shouldn't be an issue, because the cost, for example, of the SGLT2 inhibitors is negligible. And if you just prevent one rehospitalization, then you fully pay for that. So that is, of course, we need to be wary of using a more expensive drug like sacubitril valsartan and switching all patients on ACE inhibitors if they are not fit to the definition of paradigm HF, because in that case we are wasting money. But the cost is not a major issue. Polypharmacy is an issue because often, it's not just the 6 drugs that patients are taking because of cardiovascular disease. We see many patients who are elderly, they take medications for other different conditions, and you may tell patients, oh, you don't have to take the NSAID, but then when they get their arthritic pain, they've said, oh, doctor, you know what, I will take it anyway. I don't care because the pain is significant. And in order to address the polypharmacy, then the fixed-dose combinations are very important. I think we need to move like the hypertension field has moved and go into fixed-dose combinations, and possibly the first one I would suggest is a beta blocker plus an ACE inhibitor to start, and then in the future probably we'll have the SGLT2 inhibitors as well, because in that way you can slowly up titrate. The thing with the fixed-dose combinations is that often doctors like to play with the dosage, but a fixed-dose combination can be used as substitution therapy. So once you've got to your target dose, then you can substitute your doses with the fixed-dose pill. So, but I would prefer initially a beta blocker and ACE inhibitor.
And what about the SGLT2 inhibitor and MRA, where you have nearly no titration problem here?
Absolutely. The only thing is that then that will require probably a closer monitoring because of the MRAs, and it's of course it's a sound association. But if I had to choose, I would go first for that one and then for the other one.
But you just said that there's sodium glucose transport inhibitors are good if you combine with mineralocorticoid antagonists because you have less hyperkalemia.
Yes. Right? No, absolutely. The thing is, those patients who are the outliers, those who get up to 6 millimoles. And
Piotr. Giuseppe, we are now binding up the whole guideline-based concept on this fantastic or whatever however, which is quite a reasonable approach, particularly taking into consideration the results of randomized clinical trials. But if you as a regulator in the past, specialist in the clinical trial and incoming Heart Failure Association president, if you look carefully at this other drugs, so are we ready to challenge the Fantastic 4 maybe to Fantastic 5, 6 and maybe 7 if we look at the Victoria trial? Whatever we say, the trial met its primary endpoint. Whatever we say, it met, we can debate. Then there was a Galactic trial which also met its primary endpoint. then several other approaches. I don't want to challenge Wilfried, but I will, when the time will come. But why not, maybe there will be another drug number 7. Are we ready for this, so to change the paradigm and say maybe there are magic 5, 6, 7? What do you think? Is this reasonable?
Yeah, you've been chair of the guideline committee once, so you know very well that that very much depends on the philosophy you want to have behind your guidelines. And the guidelines this time, they took an approach that is just to prioritize those that reduce mortality, which is wrong, which can be right or wrong, because usually the vast majority of trials use mortality and morbidity as a primary endpoint, and therefore drugs like even ivabradine and vericiguat and omecamtiv mecarbil, they should be considered as positive, because the trials were positive. They were designed for the combined endpoint and not for the individual endpoints. And this is the reason why the European Medicines Agency has granted the approval for vericiguat more recently, and that gave the extension of ivabradine in the past after the SHIFT trial. But of course, yes, the answer is yes, we should expand the numbers.
Are there any questions from the floor regarding Professor Rosano's presentation? If so, please go to the microphone, because otherwise we will move to Professor Moulen's presentation, which will be moderated by Piotr.
If not, it's my privilege to invite Professor Lucia to comment on this presentation, and then we open the discussion. Come, please.
Well, thank you very much. I mean, Wilfried, I liked your lecture because it emphasized that you're a clinician and really think about the patient. I like this a lot. And, you know, I'm also fighting with the 3-month rule for the ICD. And I just had a patient that I revascularized, and then in December, in January, he got ejection fraction decline to 35%. And I treated with all these goodies that were just discussed. And I was waiting for the ICD, because also, as Michel Comajda said, that, you know, you have to convince the patient to even swallow what you prescribe. There's so many drugs that we prescribe now, particularly when they're also diabetic, as in this case, and hypertensive, and you name it. And then, yeah, suddenly he had an accident with his car and was still, you know, brought to a hospital, and then, of course, they implanted an ICD. So should we personalize this more? This was, of course, a patient with ischemic heart disease, and his ejection fraction was 45%, yet he had this arrhythmic syncope. So how can we avoid this, or is it unavoidable?
If you just follow the guidelines, I think it's unavoidable, but the guidelines are not a rule written in stone. Mm-hmm. So I think we have to individualize. Like I said, I think we have to try to estimate the risk for that patient that he would have a sudden cardiac death while you're waiting for the ICD indication. And therefore we need physicians. I mean, like I alluded to, if that person might have a lot of scar already on the echo or on the MRI, that would be a patient where I would think, you know, why would you wait? I mean, you know, if that patient, for example, on the MRI has a scar burden of more than 20%, he will have a VT or VF eventually during his life.
Even if his ejection fraction improved, huh? That's the dilemma is then a bit...
Yeah, there are tons of data out suggesting that these patients also will have eventually sudden cardiac death, but it depends on the age and the comorbidities there. Because his risk will, for example, not be 3 to 5%, but might be 2.5%. And if he's 50 and he doesn't have comorbidities, he will have the benefit of the ICD perhaps 6 or 7 years later, but eventually will have the benefit. Mm-hmm. If that patient is 80 with a lot of comorbidities, then you should not go for the ICD route. And then if, for example, if for logistic reasons you don't have you cannot implant the patient with an ICD, and you think he's really high risk and you're going to send him home for 3 months, you still have the opportunity for the VEST. You know, there is a portable ICD basically, which was tested in the VEST trial, and the VEST trial by itself was neutral, but that was in patients where we just said, you know, put on the vest and we'll see in 3 months if he has an ICD indication. That's different from a patient where you think or you estimate the risk is a lot higher than 3 to 5%. So I think we need physicians to actually help us estimate the risk for sudden cardiac death. But I think we all have these patients. The ones where I struggle with mostly, to be very honest, are the ones with a myocardial infarct. They come in with a myocardial infarct, they have a troponins of 6,000 or 7,000, you know there will be scar, and then you keep them in the hospital for 5 days, 7 days, and they go home and some of them die.
But the Dynamite trial was not very favorable, was
Yeah,
it?
but Dynamite was different. Dynamite was just having some extra systoles the first 24 hours after the infarct. Said they took a lot of patients in who were not really high risk. And I'm saying that the patient with troponins of 6,000, they don't all need an ICD, but we lose some. And we fail to identify the ones that in that risk will still die. And those are the ones that keep us out of our
Just the last issue is the vest. You know, if you harness an ICD in a professional manner, is this an option when you're not 100% sure?
Yes, I know, but it depends also on the finances that you have in your own hospital. So overall in the trial it was neutral, but it's very difficult in a trial to exactly phenotype the patient that you think might benefit.
Sure.
But if I can add one point here, the vest trial, I think many patients were not fully adherent in wearing the vest, right? Would you expect a higher efficiency in preventing sudden death in these patients in the waiting phase if they really wear the vest for 24 hours? Are there any
I think it's speculation, maybe, but I still think if we would deploy the vest algorithm to everybody and they would wear the vest, we would probably give it to too many patients. There is still this, I think it's mostly in ischemics with a myocardial infarct, this vulnerable phase of the first 3 months that we're missing out on patients. I think it's less than a non-ischemics, to be honest.
Wilfried, we have at least 2 questions from the audience, but beforehand let me congratulate you with a very innovative approach regarding LBBB as a criterion not to improve. Perhaps next year we are going to have a debate whether LBBB is going to be a factor precluding for any chance to remodel and to improve ejection fraction to be. So it's a pretty including concept. I love your very strong statement.
But then we have to do one thing, Piotr. The EP guy has to defend the medication and we can defend the ICD.
Okay. But anyway, there is one question related to non-ischemic HFrEF, and the question is, does CRT, I presume in those with broad QRS therapy, prove benefit in addition to this magnificent 4 therapy, ARNI, beta blocker, SGLT2 inhibitor, and MRA? Very clear question. I understand that the person wishes to have a very clear answer. 4 therapies.
If you're really honest, we don't know. But we do know that the risk in those patients is still significantly high. If you look at the DAPA trial, a lot of these patients had ARNI. Yes, their risk was lower, but it was still up to 18% in 2 years. So, and that was in a narrow QRS. At a wide QRS on top of that, there is absolutely zero reason to believe that they don't have a residual risk anymore for heart failure hospitalization, all-cause mortality, or sudden cardiac death. So the answer is definitely yes, go for it.
Well, based on, I presume that the next question would be based on not yet randomized clinical trial, but the wisdom of the physician. I would be more provocative, trying to move a little bit. Sure. Michel has got a question related to this.
Yes, I was surprised that you never mentioned the Danish trial, so I would be happy to know what is your interpretation of the Danish trial, please.
Yeah, I didn't mention, I think we had a little bit of arguments during writing of the ERA guidelines because most of the heart failure physicians were in favor of keeping a 1B indication for the non-ischemics. It's because the electrophysiologist or the representing the ERA, they wanted the downgrade based on Danish. But Danish was a trial, and I don't think many people realize that, in non-ischemic primary prevention, but half of the patients had a wide QRS. So half of them also got a CRT implantation, which changed the risk for sudden cardiac death tremendously. And their primary endpoint was not VTs. it was all-cause mortality. And they just showed that in this patient population, of which half of them got a CRT, that after a couple of years, there was no reduction in all-cause mortality. And that many people took that wrongly, stating there's no benefit of the ICD. But if you look at the second graph Kaplan-Meier curve in this study, it's very clear that the ICDs reduce sudden cardiac death by half. Meaning that if you are younger with not too much comorbidities and not advanced heart failure, there was a tremendous benefit of the ICD in Danish.
But, you know, Wilfried, I mean, the dilated cardiomyopathy are not a homogeneous group of patients. At the Brompton, we characterize everybody genetically, and if you have a laminin mutation, a completely different risk than if you have another mutation. And I think we should really move to personalize the approaches here. That's overdue, in my mind.
I couldn't agree more. That's what I stated.
Wilfried, one question, a final one, I guess, because we have 3 minutes left, related to patients with ejection fraction of 60. I understand that you agree that using your approach, that you're weighting the risk. Those with have MREF and PEF, they also tended to have a pretty high risk of sudden cardiac death. And this is the case of a gentleman who has positive family history of sudden death, dilated cardiomyopathy, 43 years old, etc., etc., some LGE amount of basal septal midwall. So, make long story short, what about ICD in this population? Would you go this direction as well?
That goes in the direction of what Tom was just alluding to. That's a completely different phenotype. We're not talking here about HFrEF patients. We're talking here about individualization of sudden cardiac death risks. So if that patient would have a mutation like Tom was alluding to, definitely we would go for the ICD. There you open up a worm of cans. Do we have to do a diagnostic electrophysiological examination? We don't really have the data. Some will say yes, some will say no. But this is not heart failure. There are a lot of patients die without heart failure of a sudden cardiac death, and this might be a gentleman that have a higher risk.
Good.
Thank you. Giuseppe, you want to comment? Yes.
Just brief one.
Very brief, and then we conclude.
Just to remember that the most effective treatment that you can give to your patient in front of you is to optimize medical therapy, because with SGLT2 inhibitors, immediately you see the reduction in events within a week. So whilst they're waiting, optimize medical therapy.
So thank you very much indeed. A great session, and it only shows us that there will be so many topics in the guidelines who are going to be challenged, maybe improved, and maybe awaiting a little bit different approach, maybe a little bit more data. So once again, thank you very much for joining, and I invite you for the rest of the meeting. Thank you.